Thank you. Welcome to today's meeting of the Health and Social Care Select Committee at London Borough of Hillingdon. This meeting is being broadcast on the Council's YouTube channel, Hillingdon London. The purpose of this committee is to monitor services provided by health partners in adult social care and review their performance. We also undertake in-depth reviews and witness sessions on specific topics and submit our findings to the decision-making cabinet. My name is Councillor Nick Denys and I'm chair of the committee. Before we start, I have some important housekeeping for everyone present. Please ensure your mobile phones are on silent, and I've not checked mine, so this is a good opportunity for me to do that. Yeah, indeed. Yes, and it wasn't on silent, so that's good. We're not expecting a fire drill, so if the fire alarm does go off, please follow Nikki out of the building. Please keep your microphones muted when you aren't speaking, then unmute them to speak. As chair, I will call on those to speak. And just to mention for those in the room, it's quite warm in the room, so if you're wearing jackets, I'm completely happy for you to take them off, by the way, if it gets too warm. So we're going to move on to the agenda. Do we have any apologies for absence?
Chair, we've had apologies from Councillor Rita Chandel.
Okay, thank you. Do we have any declarations of interest before we start the meeting? No? Fantastic. Okay. That hasn't happened before, so that's good. Are we all happy with the minutes from the last meeting? Are we all happy? Agreed. Yeah, agreed? Fantastic. Okay. Every single item that we have on the agenda tonight is in public, is that correct? Yes. So it's on the YouTube channel and anybody can watch what we say. Fantastic. Okay. So our first main item is agenda item 5, which is the carers strategy delivery update. And so we're very lucky to have a number of interesting speakers on this tonight. So what I'm going to do first is I'll suggest that maybe when you're asked to speak, stick to maybe 5 minutes or maybe a little bit longer. And I might sort of, if you're going above that, because I know you're passionate about this area, then I might pause you because obviously there'll be a chance for us to ask questions and get into a debate. But what I'd like to do is I'd like to start with Gary Collier first, who's the Health and Social Care Integration Manager who wrote this great paper for us. So, Gary, could you please introduce it?
Thank you, Chair. Good evening, everybody. The report you've got before you today is the annual update on the carer strategy delivery, which is a sort of precursor to what will actually be going to Cabinet in September, and is intended to give the committee the opportunity to consider. In this instance, the update on 23-24 actions, to look at the suggested priorities for 24-25, as well as considering some of the case studies within the report that are intended to help to make it real for the committee, and that was well received by the committee the last time it considered the update on the carer strategy. Just a few points, Chair, to highlight. We have actually undertaken some more consultation on the carer strategy. That has now concluded. In short, the feedback from that was positive. Some key changes are actually going to be made, and that is mainly to some of the wording within the strategy to make it more accessible. So the intention is for that to be signed off within the next couple of months, and that will be by Councillor Palmer and Councillor O'Brien, on the basis that the strategy covers both young carers and older carers. The members may notice that there is some repetition within the strategic context from the last report, and that is deliberate on the basis that I thought it may be of assistance to the committee. Next time round, I won't do that. What I'll do is I'll make reference to this report to help again to reduce the size of the report. Just a couple of other items I think to highlight before Chair, you open it up to partners. On in the performance section of the report, which is on page 18, reporting against some of the national measures under the short and long-term services criteria, which shows that carers supported per 1,000 18 plus number of carers is actually lower than some other London boroughs, particularly Westminster and Kensington and Chelsea. An equivalent situation in terms of direct payments. Important to point out that the SALT definitions are actually quite strict. So those figures do not include the numbers supported under the Carer Support Services contract delivered by the colleagues that we have here today. That having been said, I think there are certainly some potential learning points from Kensington and Chelsea and Westminster because they do actually have higher numbers being directly supported by the local authority, which means that they've got higher numbers actually receiving carers assessments, and the committee may recall from the November report that we do have high numbers of carers actually declining to receive a carers assessment. So I think part of the learning is, well, what are they doing differently to ourselves, and we will take that on board. But I suspect that colleagues may have something to say about that. I will leave it there, Chair, to give the opportunity to speak to our partners.
Thanks, Gary, and thanks for your report. And I do have to say the case studies were especially interesting, both to give us a feel of the type of issues faced by carers, but also as well in terms of the support we can give, and essentially those pathways to how we know about them in order to give them support. So the case studies are very appreciated. Okay, so I'm going to go to each of our partners now, and I'm going to basically ask you to sort of explain what role you play in the carer strategy, and then maybe if you comment on some of the things that you think work well, and please, if you think there's some things that can be improved, please also mention those as well. So I'm looking at you, Sally, because I'm just going to go round that's the way we're going to go. So if you want to switch off on your mic, could you introduce yourself and then talk a bit about what you do?
Certainly. I'm Sally Chandler from Carers Trust Hillingdon and Ealing, and we are the lead partner in the Hillingdon Carers Partnership. That was formed back in 2015-16 when the council aggregated a number of carer support contracts, and we organised ourselves as a partnership. The main purpose of that was to provide that single point of access, which is very common across health and social care services, but to prevent carers having to tell their story multiple times. And I will pick that up about carers assessments shortly. So the partnership has been working well together now for 7-8 years, and we meet regularly. And what we tried to do was just create a team without walls. So we subcontract a series of specialist support. We provide all the general support for carers, information and advice, and young carer services and young adult carer services. But we commission Hillingdon Mind, Angela and Evelyn are here, for specialist mental health support, and I'll ask them to talk about that. We commission the Alzheimer's Society to provide specialist dementia support. Unfortunately, Tabor from the Society's on leave. I'm presuming she's not here. And then we commission Hospice Harlington Care to provide some therapeutic support, but also predominantly the Carer Short Break Service, which is regulated respite care service to give carers a few hours a week under the contract to have a break from caring. So that's how we're organised as a partnership. We're really well established. It works brilliantly, and I think carers appreciate that we get the permission as soon as we register them to share their personal information so that the right services can wrap around them and they're not having to approach multiple organisations, and that works really well, and the staff work really well together. And I think it's been a very successful model that we hope to see continue into the new contract. In terms of some challenges, bringing up the issue around carers assessments, we do have a huge attrition rate, carers just not wanting another assessment. they spend their lives being assessed by GPs and hospitals and social workers, and when they come to us, they say, I just don't want another assessment, I just want a break, or I just want some help from you, or I want some advice on carer-related benefits. So there's a tension for us, because obviously we completely understand that the council's statutory obligations are to report on the numbers of carers assessments that are being done. And if we're directing resource to try and encourage and do a lot more carers assessments, we're detracting from what carers are telling us they want by not having as strong an offer. And I would say, because I network with all the carers organisations across Greater London, the carer offer is second to none in Hillingdon. They have some fantastic services, and they would tell you that as well, and I don't think they want to lose those. Another issue for me, for us, is that kind of closing the loop with social care. So we will often refer carers on with their permission if they need a joint needs assessment, or if the person they care for needs more support from social services, and it's then very hard for us to find out. And I would say that was more of an issue for the whole third sector, but obviously we understand again the barriers with GDPR and how that information loop can be closed. So that's a tension for us. And I will bring colleagues in briefly, very shortly, about mental health issues. So since the pandemic, we have seen not only a significant increase in carers struggling with low-level mental health issues, sleeplessness, anxiety, depression, but we're also seeing far more complex needs coming through the doors. Just on a brighter note, because those are the challenges, we have been hugely successful at drawing down money into Hillingdon. So for carers and their families, last year we raised over £1.5 million in carer-related benefits for families in Hillingdon, which is the highest figure for a long, long time. And since the start of the contract 8 years ago, we've drawn down resources of nearly 1.8 million from grants, big lottery, whatever. So the services have been enhanced, and we've been able to expand the support offer to carers. So the role in the strategy, we're part of the multi-agency carer strategy group, alongside the council, health services, primary care and others, and we work really, really closely to make that a joined-up service and to try and feed the carer voice into the strategic aims and objectives of an integrated system. So I will bring colleagues in from Mind, if that's all right.
So please, obviously, introduce yourselves and just explain why you are here.
There you go. Got a red light, so it's on. Okay, I'm Angela Stango. I'm the Chief Executive of Mind and Hillingdon.
And I'm Evelyn Cecil, Assistant CEO and Head of Adult Mental Health Services.
So basically we're involved quite intrinsically with our partnership with the Carers Trust, and to be honest with you, through H for All, the other partners here. Our sort of role is very much in supporting carers who look after people with mental health issues. Part and parcel of that, unfortunately, is that often they end up suffering from poor mental health themselves. So we offer a range of activities, including counselling, for those individuals to be able to take time out, offload, and talk about what their issues are. Because it's a wraparound service and we're involved with the other charities, it allows us to sort of feed information between. So if we can't offer a service, we can feed it back to the other services that can. And that's one of the big benefits, I think, of this partnership and this crossover in working together. I'll pass over to Evelyn in a minute just to talk very quickly about the operational side of it, but one of the great things about the partnership as well, and Sally's already covered this, was that the Big Lottery gave us quite a large grant for the next 5 years to look after the psychological side of looking after carers as well, to top up the existing sort of payment that we receive from the Carers Trust and LBH. The reason that we needed that was because of the increase in demand services, and we'll talk about complexity because Evelyn heads up the social sort of workers team that look after those cases.
Thank you. So I just wanted to reiterate really what Sally's already mentioned about, this seamless joined up approach, and that's been really, supportive for our carers, being able to help them access that timely support as well, and not having to repeat their story as well, really, really important. So, on the operational side of things, as you've already mentioned as well, Sally, we are seeing much more complex cases coming through. As we probably all very much aware, the cost of living, the after effects of COVID and sort of social isolation as well, still impacting people. And we've been very much listening to our carers, and I've worked to sort of co-produce all of our services to make sure that they really are meeting their needs. And as you've rightly said, with that emphasis on psychological support and well-being, but also within our team helping people have access to a wide range of information and guidance as well, and working closely with our partners as well to make sure that we can signpost and direct them effectively. And we've been quite lucky as well to be able to work closely with CNWL, so we have a new carers engagement lead in post, and that's enabling us as well to not only support the carer but the person they're caring for as well, and again working alongside our colleagues. We've been able to develop workshops both through Carers Trust and with CNWL as well, to make sure that the advice and the sort of psychoeducation side of it as well has been put in place. We've also got some quite creative groups as well that we run, and again that's in response to what our carers have asked for. So we've introduced ecotherapy, psychotherapy groups, so taking a very holistic approach to their well-being. And as you've said, Sally, very unfortunate that we are seeing much more sort of complexity in the casework, and obviously with the corresponding demand on time for those cases as well.
Thank you very much. And finally, before we go to questions, Steve, could you introduce yourself and talk about the role you have in this?
Yes, good evening. I'm Steve Curry, Chief Executive of Hillingdon Hospice, and in the Carers Partnership, we're a partner. And as I said, we do two elements. The main element that we actually deliver is the carer short breaks. So we've got a domiciliary care a service called Hillingdon Care, which provides between 2 and 4 hours for a week break for carers, and I think it's fair to say there's about 70% of those are for carers who are looking after someone with dementia. These are people who are actually finding it very hard to leave the house, who are actually stuck there. So this is it's quite often a lifeline to individuals who actually can actually deal with some stuff for themselves. So some of it is just actually to have a break, even if it's just to go and lie down for a couple of hours and have a break. The other thing is just dealing with the practical things of dealing with doctor's appointments and things like that. So the service we offer, we work very hard to keep the same carer going to that team all along, and we flex the hours around the need as much as we can around the situation. So we have to be because of the financial resources, we have to be limited about the time we can give to individuals. But what we can do is they can, if there's a major thing coming up like a wedding, they can bank those hours for a couple of weeks and then have that time away. The other bit we do is we do some therapeutic support, and we do some work with particularly with Carers Trust around caring with confidence courses as well, and things like that. The other bit, which is it comes out of this partnership working, which for us is and is really important for the people, the carers who we support in our hospice services, is that point when we're looking at immediately before a death, and definitely post-death or during a death, during the time of somebody actively dying, is quite often we because of the partnership we've got, we will actually support provide services for people jointly, and particularly around our children and young persons bereavement service, where we offer a pre-bereavement support, and where there's quite often a situation where young carers have been caring for an individual for a long time, and our two teams work very closely, whereby Sally's team will fetch young people or a sibling group to our services and support that situation. And that's also particularly when you're dealing with children on the neurodiverse spectrum as well. So there's those sort of situations, and that partnership working that we do, which is being built through this partnership, helps those wider sort of work we do much wider. I mean, Angela mentioned the H4 partnership, but that's those sort of things. It's hard to put a value sometimes on that sort of relationship building that we build within the teams that actually enable a much more holistic approach to people's care.
Thank you very much. And sorry, is it Tabor? Fantastic. That's all right. Don't worry about it. Driving in Hillingdon or public transport even to get out here can be a bit of a nightmare sometimes. So yeah. And I mean, finding your way around the building. I mean, I've been a councillor for 10 years, but I only stick to about 15% of this building. So completely understand. But that's okay, because what we're doing at the moment is all our guests are introducing themselves and essentially just saying what part they play in the carer strategy, but also talking about what works well and any ideas for things that can be improved. And then we're going to open up for us councillors to ask questions. So if you'd like to sort of take those, that would be really appreciated.
Yep, is that on? Yeah, so I'm Tabor Zaria and I work with Alzheimer's Society as the local service manager. And our part that we play in the carer strategy is that we work in partnership with carers, Hillingdon Carers Trust, and we deliver the dementia support side of things. I think we have a really fantastic model with all the partners, so not just with Hillingdon Carers, but with Harlington Care, for example, H for All. It means that it's a one-stop shop for carers, so instead of them having to bounce around different services and repeat their story over and over, it's actually an opportunity for them to just say their story once and have all the services that they need from one place, so they can, get financial benefit support, their carers needs assessment, as well as actual emotional and practical day-to-day support that they might need when caring for somebody living with dementia. I would say I think the biggest challenge for us has been the growing demand. So we know that the diagnosis rates are only going to increase over the next coming years, particularly in minority ethnic communities. So I think that's something that as a service we've already seen. For the number of staff we have, it's just not enough for the growing demand. So I think that's something that we've been working quite closely with Sally on and trying to sort of manage that while still delivering good quality care has really been a significant challenge on our part. And I think that's a brief summary without going into too much.
No, that's great. Thank you very much. And we'll sort of all go into questions. And by the way, when we ask questions, anybody can respond. I mean, we might direct them, but if you have views on them, please do let me know and come into them. So I will ask a couple, then I'll open it out to the rest of the councillors here. So the first question I want to do is I want to delve a bit more into the issue, Sally, you raised about people not wanting to be assessed again. I can completely understand that, and obviously, rightly, you talk proudly about not having to repeat stories, because I know that's something in other aspects that we've looked at can be very, very, very frustrating for people. But obviously, there seems to be a case that in this, people will have to repeat stories. So, I suppose, how have we looked into improving this? You mentioned GDPR, but is there ways of getting permission? Is there a way of streamlining it, making it quicker, the system? Obviously, communicating the benefits of what somebody will receive is there, I mean, have we looked into, are there other places that do this sort of better, and can we sort of get over this bit which is stopping people who need help to get help?
Yeah, I mean, we've worked very closely with the council to look at the process of a carers assessment, and what we have done is created a two-tier system. So we've simplified what was the requisite face form from government into a tier 1, so that we're not doing a 30-page document with them, but we have triggers in that assessment that if we have any concerns about the complexity of that caring role or that those carers' needs, it automatically triggers a tier 2 or a joint needs assessment, which is referred to social services so they can assess the carer alongside the needs of the person they care for. So we've looked at simplifying the process significantly, and I think that is the way forward, particularly as we think we're going to be looking at young carers assessments as well, which we haven't done historically. So we need to simplify it. What I would say is, once we're actively working very closely with carers, you build that picture very quickly. We don't need to necessarily have that whole, huge, because depending on the carer, a carer's assessment can take anything from half an hour to half a day. The other thing we've done is to try and prepare carers better for assessment, so we give them a checklist. So these are the sorts of things you're going to be asked. A lot of carers will have so many people they're in contact with and so many people calling at their house, they don't even know who is coming through the door or who is ringing them or who is providing their services. So we have a tick list of saying, well, you might be asked about a home care package, you might be asked about district nursing. These are the sorts of things you might want to have with you or to think about. So we've tried to get carers better prepared for carers assessments. But, it's really, really difficult because they have had a sort of assessment overload by the time they hit us often.
I mean, looking at the benefits, though, if I was a carer, I'd want those benefits. So,
but they can have them. They can register with us without a carers assessment, so they can have the benefits of all the services. We have 100 free services. They can have all those benefits without, and it would be, I'm not sure, very ethical to say you can't have those services unless you do.
I wasn't suggesting that. I didn't realise that, and again, that is right. That takes away motivation from this. Okay. I mean, I think that would be, when we look at this again in next year or so, it'd be useful to sort of see if any improvements have been made with that. So thank you. And my second question is for you, Gary, and it's a big question, I'm afraid, but you don't have to speak too long about it if you don't want to. So on page 14 of your report, bullet point, paragraph 15, you talk about the main actions identified in the survey results of what carers wish for has basically been unchanged since 2021-22, and that's the explore the expansion of personal budgets for carers, including direct payments, to work with care home providers to develop flexible short break options for carers, to continue to develop the range of social opportunities for carers, including peer support groups. So I suppose my question is, if this has been repeatedly what people care most about, how come this is still repeatedly what people care most about? I mean, have we been making progress? And if so, why is it still in the top 3 of what people are most interested in?
We have, yes, it is still quite clearly what I think what people, what carers actually want. The Hillingdon Carers Partnership have been very successful in actually increasing the range of short break options available to carers, actually in response to what carers have said to them. One of the issues that we do have that we frankly haven't been able to address yet is the issue of bed-based respite, and there is a reluctance on the part of providers to make that available for any less than 14 days. So we are still working on that. However, the solutions to that are not quick to deliver. And will take time to put in place. The issue around direct payments and linked to personal budgets, again, is quite a big piece of work that does take time to actually implement, and some of it is actually linked to systems, and some of those systems are ones that we actually buy in and therefore don't change quickly. But that particular point has been identified as an action to look at for 24-25, and I'd like to sort of refer back to a comment I made in my sort of preamble. Is what I'd also like to look at is the offer actually being made by a couple of those inner London authorities that actually have significantly greater numbers of carers actually receiving direct payments. Again, so the learning about what is it that they're doing that's different to what we're doing.
Thank you for that, and luckily Nikki's making a note of all that, because in a sort of year's time when we look at this again, I think I'll be interested in sort of some more details around those. And I know, because I read some of them in the report is about stuff we're moving forward on this, but some of those things would be useful to know in a year's time where we've got to. Otherwise, I'll just ask the same question again. But thank you for that. Okay, so I'm going to go to June first.
Thank you, Chair. My question is to Steve and Sally, and it probably impacts on you as well in regards to the wraparound care that you give. First and foremost to Steve Harvey. I know you said in your report that you're working collectively together and help each other. But what you haven't said is that Hillingdon Hospice is being sold off. And from the last report, when we had a committee petition here about Mount Vernon Hospital, and I was actually going to raise it on the Mount Vernon Hospital, but I have the opportunity to raise it here as well, is that Hillingdon Hospice was going to work in partnership in support for those support with palliative care, and the extension of beds as well was considered at the time, that we're looking at extending the beds with the QCC. At the time it was the QCC, who was the healthcare provider, who was providing the healthcare service at that time. So now that the Hillingdon Hospice is being sold off to Heathrow Airport, I'm just telling you what's coming back from the community, okay, because the community is the one who informed us of what's going on, because we weren't aware that this is what was happening. So therefore, how is the wraparound care with the patients? Because you state here that you also gave support with carers with dementia. That is a very demanding service at the moment. The palliative care, the daily palliative care patients within the community. In that area, the community have very limited facilities for any of those. They will have to travel out, either over to the north of the borough or outside of the borough. So what is going to happen to those residents who is registered with you? What's going to happen when your services is no longer available? Because if the site is sold off, then where is the provision for that to continue to be supportive of the community? And therefore, we wouldn't have nothing for the community within that area. Can you tell me how is this incorporated into the wraparound service for both mental health, for both carers, young and old, and also for people with palliative care? I'd like a really clear answer on that. Thank you.
Thank you for giving me the opportunity to answer these questions. I know we've got a meeting coming up on Friday, which I'll go into more detail, but what's happened is that as people have been aware, there's been a lot of publicity recently around hospices having financial challenges, and we are no different to that. In fact, we were one of the Michael Sobel Hospice was actually filmed for the ITN news on that one. What we've done in Hillingdon, with Hillingdon and Michael Sobel services, we've been reviewing where our costs are and taking all of our costs out without cutting any services down. A lot of other hospices, there's a lot in the news at the moment about Birmingham hospices looking to close beds. We're actually, if anything, we're actually opening beds in our Michael Sobel side of things. As part of the review, so that we don't continue to close services, we've already taken a lot of costs out of our central costs. We have been reviewing everything. We've got a property at Lansdowne in Hillingdon. Lansdowne House it's a really nice property. I've worked there for 11 years. It's got a lot of resources there, but it's really underutilised. We've got two services running from there at the moment. We've got our emotional and psychological services, including our children's services, and we've got some lymphedema services running out of there. But the building is currently used less than a third of the time. We have explored opportunities to build bed spaces there, and we have had several discussions with the planning department. We've got the advice we've been very clear, being told us that we cannot, we will not get planning permission to do an extension to the building. The building, we can't convert the building internally into bed spaces and have it economical to run. Just the layout of the building just doesn't work to that situation. So when the situation is now at the moment, it's costing us over 60,000 a year to run the building. But most of the time it's empty. It's a building we can't convert into the service that we wanted to convert into, which is the shortage in the south of the borough is the inpatient beds. There's no beds there at the moment. We are, in terms of selling the building, it is about to make sure that we can continue to provide the services. We are looking at alternative places on this sort of things. And to be very clear, we haven't sold the building to Heathrow. I had tried to sell it to Heathrow and to lease it back to us so we'd have time to use the cash released from that. We're expecting to get in excess of 3.5 million, which we can then reinvest into services, and particularly around bedded services in the south of the borough. At this point in time, we've not been able to do that. So as an organisation, we have to make some difficult decisions as to what we deliver and where we cut. Up to now, we've not had to cut any services. As selling Lansdowne House, we can re-provide those services. We are in discussions. We are in discussions with several organisations about where to place them. The reality is we didn't want to sell Lansdowne, but if we don't sell Lansdowne, to be quite honest, we'd have to cut services, and that's the driver behind from the board and the executive is how do we protect services and relocate them so that those people who use those services can gain access to them. So we are talking to Vernon University. We're having some discussions. We're trying to talk to Stockley Park. We are talking to we've talked to a local authority. We've talked to health people as well. So we do need some basis for those services. We haven't. It has been marketed at the moment. We haven't got a buyer at the moment. We've got time to look at those services. We've unfortunately had to put the building on the market before we've got the alternatives set up. But we've already got backup plans to maintain those services within easy reach of the people of the south of the borough, because the services that we got in Lansdowne House we also duplicated in Michael Sobel, so we do not want to move them to the north of the borough. We need to keep them in the south of the borough or in the centre, because that's the people who are actually using those services.
June, are you going to be going to this meeting? Are you going to go to the meeting on Friday?
I'm having a meeting.
Okay. Can I make a suggestion? Or Sally, did you want to come in for?
I believe we were asked about generic carer services as well as the end-of-life piece. So just to say that we're very clearly committed to delivering in the heart of communities. So we have services in Harlington and Hayes. All our young carers clubs are in your young people centres at the moment. So we're hanging on the outcome of the consultation around that, because we sometimes have upwards of 100 young people on a Saturday morning. You can't do that in a church hall. We need the specific facilities. So Hayes and Harlington is really, really well used. Heathrow villages have been an issue, and we know they're an issue. We did some extensive consultation last year there, and we piloted a carer cafe in Harmondsworth. But we were only getting one or two carers, and we didn't have the resource to keep staffing something that wasn't working. A lot of the carers were saying they were happy to travel to Harlington and Hayes. So we're very, very careful. We have them in Northwood, we have them in Ryesett, we have them in Uxbridge. We're very careful to make sure that carers have the services they need as close to home as possible.
Sorry, I just want to make a quick suggestion.
Yeah.
As you're going to the meeting, the main meeting on this on Friday, which I can't make, unfortunately, I think the Harlington hospice issue and general hospice care within the borough might benefit from a more in-depth specific meeting on our part. So after you've been to that meeting on Friday and heard more what's going on, if you believe that is the case, if you could message the committee, maybe next time we can meet, we can decide to actually have a proper full meeting on this matter with Steve and others involved, because the issues you raised are important. Thank you, Steve, for your response, but we might need to look more in depth at this.
I would like it to be more in depth, because it will impact on the hospice over at Mount Vernon. That will impact, and this is part of it. So yes, we do need more in depth, in perhaps a discussion around this committee in regards to that, because it's impacting both ways. And it will impact our residents in the borough here, in both the north and the south of the borough.
Okay, well, maybe when we look at our work plan at the end of this meeting, if we can think about a time to look at this area specifically. Okay, thank you very much. Philip.
Thank you, Chairman. I mean, first of all, I would say it's great to see the report. It's good to see the partnership coming together as it is, and really to see how it's developed over the last few years. I mean, looking at Sally there, you've been the mainstay for a very long time. You and I go back quite a way too, don't we? But it's good to see the extent of the partnership, and I think it does demonstrate the, a very good example of the benefits of integration, actually, in this area of service. So I welcome that. I do have a couple of questions. One relates to the methods by which you engage with carers to help shape services. You've touched on this in your presentation, but I wouldn't mind to understand that a little bit more. How can carers make their voices heard and influence the shape of provision in this area? The second one I can just go on to quickly, or do you want me to wait for an answer?
Let the people here answer the first question, then you can ask a second one, Philip, okay?
Whoever wants to have a stab at that, please. Thank you.
I'll pick that one up, yeah. So we absolutely have co-production and consultation in our DNA in the third sector, really. We wouldn't ever dream of putting on a new service or designing a service without the voice of a carer there, because it's a waste of resources. There's no point me sitting in my office saying, I think we'll do this, if nobody's going to use it. So we have multiple mechanisms for carers to influence and to I'll start with children, young people, because that's a bit more challenging. So for our young adult carers, they design their whole programme. They have pizza and planning and chicken and chat nights. As long as there's food involved, we get a good turnout, and they're very good at designing that transition piece. Children and young people as young as 5, we have iPads at clubs, and they do happy spaces and sad faces and design the sort of things they want, their school holiday programmes, the activities they'd like to do at clubs and things. So young people have a voice as well. But for adult carers, we co-deliver a carers forum twice a year with the council, and we use those to give carers a voice in, well, any hot topics. So the carer strategy has been a number of times, I think, Gary, hasn't it? And but we also have multiple armchair opportunities. So we're very conscious not all carers can get to meetings. So we have telephone chat groups, and we have focus groups. We also use our carer cafes. So we have 5 carer cafes that meet across the borough from Northwood down to Hayes and Harlington, and they will often be asked to give their opinions on the topic of the day or a new service. I think I mentioned we'd brought in £1.8 million. The reason we are so successful at bringing money in is that we don't just apply for money for the sake of it. We make sure we have evidence of a need for a service, and that carer voice in that, and that's what secures us the funding, really. So we're very, very good at, we have a good hit rate at bringing in that resource. And we also consult at every contact. So if we do a training programme, we'll do pre and post assessments. If we do a social activity, they'll do a quick form afterwards. So we have that kind of review and of all our services as an ongoing basis. So we have a whole range of mechanisms. We also have carers, which has been challenging, but we have carers that sit on the carer strategy group that we support pre and post to go through the agenda. 67% of our board and staff are carers of lived experience, so they're not just working with carers. They're carers. I'm a carer myself, so that's been a big part of it as well. Does that answer your question? Good.
Moving on to the second question then, and that's really looking to the future now. You've all touched on the demographic changes that are driving demand and will do in the future. We all know that's going to happen. I just wondered, are you able to say anything about emerging thinking around that, and how this kind of support could be sustainable in the future? Or is that one for another day, or is it something you're kind of working on at the moment?
Yeah, let's bring in some of our others who've travelled here. So definitely get your opinion on those as frontline sort of deliverers of services.
I think this is something we've been looking at for a while, isn't it? And one of the things that we've sort of looked at, and I know that Sally, you do this, as you've already said, with your cafes, is to actually sort of go out as much as we can into those communities. You know, to have as many sort of awareness raising sessions, and if needed, you know, can we actually look at putting the support there with people who are culturally competent as well, because that's the other thing, you know, there's no point in us going out if we don't have the skills to support people. So I was just thinking about some of the resources that Mind are starting to develop, you know, making sure that our generic resources are available in different community languages, or that we have interpreters as well. I mean, I was just thinking about some of the outreach that we've done, and, you know, just to make it accessible, you know, we made sure it was in the community, that there were childcare resources as well, and that people had access to an interpreter as well. So it's just an example, and it's just, I suppose, developing and building on that as we move forward.
Yes, similar to what Evelyn has said as well. With Alzheimer's Society obviously being a national organisation as well, we've got a wealth of information online, but as an organisation, one of our aims is to always try to reach people as much as possible that are affected by dementia, and we know that often people from marginalised communities may not necessarily come and approach us. So we do lots of mapping exercises to sort of keep up with the changing demographics and making sure that we are actively reaching out to those communities in a way that is culturally appropriate for them. So, you know, recently, well, not too recently, but sort of a couple of years now, we've been running a dementia cafe at a local Gurdwara that seems to be running really successfully. And it's not our usual cafe style, but it meets the needs of those people attending, and on the back of that we've been able to start a big piece of project actually with a local Farsi Action Alliance charity based just on Uxbridge High Street, and yeah, so we're looking to sort of start something similar with them to support their community in one, getting a diagnosis, because often those communities don't even have a diagnosis. So that's the first point, is sorry, from my point, dementia obviously, so to get them to have a diagnosis, and then that opens up the doors for all this extra support that they're entitled to but usually unaware. So yeah.
I think your question was about eking out resources and how we meet growing demand, and just to say we use every trick in the book to do that. So we have something like £50,000 worth of extra resource through volunteers who help us with delivery of all those services. What we do is train carers to run peer support groups, because we know carers get a huge amount of support and information from their peers because they've experienced that. So we try not to always have to have paid staff involved in some of the services. So there's a whole range of ways we make every penny stretch as far as it can. We're looking at CSR, corporate social responsibility, and I know, Philip, you were one of the first people to introduce me to some brilliant work we did with Lloyds Bank, and you gave me that contact 10 years ago. But we do look at local business, and particularly for our young adult carers, we have a great range of opportunities for apprenticeships, work experience, job readiness stuff. So we will find the resource wherever we can to maximise that.
I think you've got my drift very well there, Sally. Thank you. But thank you, everyone, for those responses. Thank you very much.
No, very interesting answers. And I'm a big fan of going to where people are, actually. I think that's one of the most powerful things you can do, especially with stuff which might have stigma attached to it. Thanks, Philip. Tony.
Thank you, Chair. Just a question really about young carers. It's quite impressive that the carer register seems to have caught the majority of young carers, and I presume you use the same figures as the census uses for a young carer up to 24. Seems to got a high proportion of them compared to other carers. Is it because people drift into being a carer and don't really? I'm talking from personal experience as well.
If you said to an elderly lady who had a husband with dementia, she's just his wife. You know, we wrap around our families, we look after families when they're poorly. With young carers, it tends to manifest in their education, often in their personal development, so you will pick those up through our schools programme. And we've been doing a lot of education with schools and encouraging schools to develop their own provision and do a Young Carers in Schools award. And one primary school in a week, once they understood what a young carer was, referred 33 children from their classroom. So 61% of young carers we identify with adults, we're only hitting about 23%. And that is largely because people do not recognise themselves as a carer. It's a challenge.
I'm surprised the numbers went down in the census from 2011 to 2021. Although, you know, obviously the Hillingdon population's got, yeah, you check your head, yeah. Yeah, just
to come back on this, Hillingdon was not unique in respect of that very unexpected result from the 2021 census. I think I said in the report, it's been attributed to a combination of the fact that it occurred, the census occurred during COVID lockdown conditions, and the question that was asked was actually changed as well. So I think it's a case of many people who were in a caring situation just did not recognise themselves as carers, and were probably confused by the question.
Just one more. The Young Persons Centre in the south, is that Hayes is the one class in the south, is it?
Hayes and Harlington we use every Saturday for our young carer clubs. And we also have a young adult carer club there on every other Tuesday evening.
Is that the community centre, is it?
Yeah.
Yeah.
Okay.
Thank you.
Thanks, Tony. Okay, and I've got Cyril down, so if you can have a couple of questions, and I'll wrap this item up because we've been speaking about it for almost an hour.
Absolutely. Happy to come in at the end, actually. First of all, I just want to echo some of the comments made about just the fantastic partnership working, because it really the report, but just hearing you talk about the services that you deliver in such an in-depth but also a hands-on way is amazingly reassuring. I have a particular, as always, like Philip, resources, and the growing concern of the amount of people registering is beyond the targets that were registered, and quite considerably beyond the targets that were registered. How is that? Because I know you say you look at voluntary people, but actually that can't meet the challenging demand of increase in these registrations that have come in, and when they are so significantly high. How is that going to be met, and how are we thinking about, if that's growing at this rate, what's going to be the next rate and the next rate? And therefore, I just would like to see what kind of mapping is being done there and what kind of forecast planning is being done there to meet the needs of carers that are growing, clearly.
We have had to make some very tough decisions. What we did with adults and young carers, but the young carers is easier because we're talking a much smaller volume of people. We had a generic group of 1,000 and odd children, young people, that we didn't understand. So we had to look at the impact of their caring roles on them. So we developed a tool that enabled us to look at so some young carers would leave club and get into a 4x4 and go camping in the south of France with their parents. Others had no trusted adult in their lives, and they were literally washing, dressing, feeding their siblings, running the house. So we had to look at that in much more detail and have a better understanding. What that's enabled us to do is target those resources where they're most needed, and that has meant saying no to some people, and that has been tough, and we have to make those tough decisions, but we need to make sure that the people that most need those resources get them, and so we've been doing a lot of work on a better understanding of that.
Do you therefore feel that there needs to be some kind of recruitment policy or some kind of I don't know, bringing more people into the system to support, or is it just that we're going to just divert to where
more
it's needed?
carers into the system?
No, not more carers, more support services into...
Everything is dependent on resource, and there are always competing priorities for every contract. What we have been really good at is bringing in new money and new resource, and as I say, eking out what we can. What we're trying to do is look at economies of scale. We have a really good model that we're very involved in with H4All, where we can push resource to the front line by sharing some of the kind of management backroom stuff. What we've now done is secured a contract in Ealing. Whilst that has no impact on carers in Hillingdon, it's a completely separate team, completely separate pot of money. It will enable us to make some economies through backroom services. So again, more resource. So there's lots of different ways we're looking to. But yeah, I mean, if you gave us the whole council budget, we could spend it. There's enough need there for sure.
I mean, thank you very on that point. Actually, I'd like to bring some of the frontline partners in on that to talk about how they deal with, obviously the door being knocked on a lot, and how you deal with that situation. So, Angela.
You're probably going to get 2 for 1 here, actually. I mean, I think one of the other things that's been great in Hillingdon about the partnership working, for instance, is the fact that a lot of our grant providers will only give specific grants to specific charities at any one time. So it's been really interesting through our partnership, because actually the carers psychological provision originally was just purely through the Carers Trust. When that expired, we applied for it, and they basically gave us a new award for that piece of work. But the reason that worked was because of the partnership, and if we didn't have that, we would have lost the ability to actually almost give the same piece of money, but with a different heading on it. And that, that's pumped over the next 5 years another £600,000 into the carers partnership and the psychological provision. So I think that it shouldn't be underestimated, the third sector working together.
Totally.
Yeah.
I just wanted to add in really sort of about that frontline work and perhaps a better use of interventions to provide perhaps more resilience and self-care strategies. I think particularly within the sort of mental health side of things, and enabling people to be able to navigate around what's available, so that we don't have to do it for them. I think that's very much sort of our approach, and as much as possible trying to, as far as sort of our workforce is concerned, looking to collaborate. So as an example, we collaborate quite closely with Buxton University, and we have social workers come on board. So for those periods of time, we have extra support within our workforce as well. So.
Just sort of echoing on from what Sally had said earlier. I mean, for us, there is a lot of reliance on having volunteers to support us with a lot of our work, but of course that doesn't take away from the services that staff can deliver. But equally, of course we're in partnership with the Hillingdon Carers Trust, but we work very well with the memory clinic, so trying to pick up on resources there. So for example, we've recognised that a lot of people that are perhaps waiting for a service just need an urgent piece of advice, or to just be signposted in the right direction, and often we're coming to them too late. So for example, with the memory clinic, we've started drop-in sessions, so where they can speak to an occupational therapist, a nurse, dementia advisor, or a social worker, and get that sort of advice there and then. And so that's sort of being advertised, and what we're trying to do now as well is that once someone receives a diagnosis, that they're automatically sort of told to go along to this drop-in session, so that people are not just left waiting for a long period of time. So I think, just echoing what everyone else said, it's really about sort of finding the resources within the borough and the contacts to who you can sort of partner up with and do sort of shared working and shared resources.
just the other side of the coin is resources are tight now, and I think the when resources are cut or there's not enough resources to support carers, there is that builds up a sort of head of steam that actually has an impact on the statutory services. The prevention element of supporting carers, we see it from the hospice point of view. We see things at the very heavy end. You might be a couple that are being codependent for a period of time. One's health deteriorates. That actually, if that home situation breaks down, if it's left too late before some support is put in, particularly if you're dealing with grief and stuff like that afterwards, after somebody's died, in a family situation, if you've got a parent died with young children, if the caring element of that, the whole prevention of stuff, my fear is that as when it gets tight, the prevention stuff gets taken away, which actually has an impact on people's lives and also has an impact on the services. They become more critical at the point when they're being picked up by social services and health.
Actually, it's probably not so much of a question, but yes, prevention stops the filling at the end, and it always must be the holistic way to look at things. I just wanted to pick up on the minority ethnic challenges that you have within, especially with Alzheimer's and dementia, because I think that is a growing concern, but also a very difficult challenge to navigate around. Culturally, the mindsets are different, and how people look after their families are different. That we've got to go through that. I just commend you on what you're doing with the Gurdwara and then with the Farki Clinic and looking at models and taking that forward. I just wanted to ask that, is it limited to that, or what else could be done to kind of get more in touch with these communities across the sector?
So I know as an organisation they're doing a sort of a large piece of work at looking at digital and tech things as well as to how we can sort of get people on board. Similarly, as an organisation, we have a lot of we call dementia voice. So that's people living with dementia, that's people caring for people with dementia, anyone who's been affected. Are again, a lot of our pieces of work are done by people who are informing us of what is needed. Similarly, we try and get people from particular communities to help inform us what's the best way to reach them. So, for example, with the Somali community, we've been told actually the best way is WhatsApp videos, short videos, is the best way to engage that specific community. So we're always sort of looking, but to engage the communities to know what works with them. Just as an example, in Tower Hamlets, which is obviously a different borough but another area that I cover, we're working with the Chinese community, and the way in which they want their services delivered is so different from anything I've seen before, but it works for them, and we've got great uptake. So it's really about finding the right contacts and then knowing how to work with them to do that, which is an ongoing process, because obviously there is large amounts or differing communities in different areas, and in different areas will have larger communities of one and not the other. So I know that there is lots of different mapping exercises happening to try and help inform as to what is the best way to lead these communities, because it's not a one shoe fits all process.
Can I just add on? Sort of very similar. I was just thinking about some of the work that we've done, as I said before, out in the community. We've been able to build partnerships with some of our smaller community groups, as I was mentioning, and then be able to provide those interventions directly. But also, being part of that partnership, whenever we have an opportunity to go out and do outreach, we will be informing the people that we're meeting about carers' trust, and trying to identify those hidden carers, as is quite rightly, a lot of the time people don't recognise, and there is stigma, particularly around mental health. So how can we look at providing the support that they're going to engage with, really?
Brilliant. Thank you very much. That was really fascinating, and for us as a committee, it's great when we get a whole range of external stakeholders coming to speak to us, as well as yourself, Gary. I know you're staying for a bit longer because you've got other things to talk about, so we do really appreciate it, so thank you very much. You're of course welcome to stay for the rest of the meeting, but we completely understand if you want to leave and go home now. Very occasionally people do stay, but not that often, it's true. Gary, would it be okay if I took Jessamy's item next? Would it be okay if I took Jessamy's item next? Is that okay? Because I know you've got further to travel than many of us to get back where you want to get to. So if it's okay with everyone, I'd like to jump to item 8, which is the Mount Vernon Cancer Centre Strategic Review. So Jessamy, if you could just introduce yourself, give a little background about how we've got here. Some of the committee members are new compared to the last time you came here, and then tell us what your ambition and plan is to what's happened next.
Thank you. Well, my name is Jessamy Kinghorn, and my role is Head of Partnerships and Engagement for NHS England. It's a little bit complicated now because in the east of England in April we delegated specialised commissioning, which covers cancer services, to the ICBs. So I now work for the ICBs in the east of England as well. So I'm here today on behalf of NHS England and the Hertfordshire and West Essex ICB and the Bedford, Luton and Milton Keynes ICB, which are both our commissioning partners in the Mount Vernon Cancer Centre. And from April next year, that will also obviously be North West London as well. So we work very closely with all of the ICBs that refer patients to the Mount Vernon Cancer Centre. So I came to you, I think, early last year was the last time, but I was just looking it up. It's nearly 5 years that I've been coming along to this committee to talk about the Mount Vernon Cancer Centre Strategic Review. So I'll do a little bit of a background. I did put some background in the paper, so I won't
doesn't have to be too long.
Too much, no. So the start of the review was 2019 when some clinicians asked us to have a look at the services, and we had an independent clinical review, so people coming from completely different parts of the country to review the services, and they had 3 broad sets of recommendations, so urgent changes that we needed to make, which we've made. Those included placing restrictions on the admissions. What was happening, one of the things that was happening was that because there was no critical care and other hospital services on the same site, if the patient deteriorated, they were being transferred by emergency ambulance to another hospital. And there are some case studies, even though we've restricted admissions, so complex patients likely to deteriorate or have underlying other conditions can't be admitted in the first place, there are still instances where patients do deteriorate and need to be transferred. So we did put those restrictions on. We recruited some additional staff. Their second recommendation was that we transfer the management of the centre to a specialist cancer centre, and we went through a process and appointed UCLH. Now that transfer hasn't taken place yet. It hasn't taken place because the third recommendation hasn't been completed, but UCLH are working really closely with us and remain very committed to the proposals that we're developing. So the third thing they recommended, they said, was that we needed to move the Mount Vernon Cancer Centre onto an acute hospital site, so a major hospital site that had the full range of acute facilities, yes, critical care, but also access to things like cardiology, endocrinology, diabetology. Cancer care is very different to how it was when the Cancer Centre first moved there. You need all of those other specialties. The cancer so the main issues that we're facing with the Cancer Centre are to do with the lack of other services that are adjacent to it. There are also issues with the buildings. It was a tuberculosis hospital, opened in 1904. Must be one of the oldest NHS hospitals in the country now. So there are physical issues with the buildings, and the other issue that we want to try and put right is opportunities, really. If we need to move the cancer centre, what are the opportunities? And one of the challenges that the staff have is they can't necessarily take part in all of the trials and all of the have all of the new drugs that are available because they don't have access to critical care, which is quite commonly required for a clinical trial because we just don't know what side effects might be. and obviously if a patient was to deteriorate whilst undergoing the trial, they wouldn't be able to be treated at Mount Vernon. So we did a lot of patient engagement. We developed some proposals, and we looked at funding those proposals. Those proposals are to move the cancer centre to the Watford General Hospital site in a purpose-built cancer centre, so a standalone cancer centre, but with a link bridge to the Watford Hospital. It would still be run by UCLH, and that we would resolve some of those issues. Watford was selected, just to remind the committee, because it's actually the closest acute hospital to the current site, and it was the only one that met all of the criteria around access and clinical adjacencies.
Can I just say that when this part of the consultation happened a few years ago, we as a committee agreed that was the best outcome. So yeah. Okay.
Thank you. So we were aware that particularly for people in some parts of Hillingdon, that was further, a few miles is still a few miles. And so one of the pieces, so was part of the proposals, we were looking at whether we could bring some care closer to home as well. So the proposals include a new chemotherapy unit at Hillingdon Hospital. There isn't chemotherapy at Hillingdon Hospital at the moment. We have asked them to incorporate that into their plans for their new building, which they have done. So part of the relocation to Mount Vernon would enable a big chunk of the Hillingdon population to have their chemotherapy at Hillingdon Hospital. I've put in the paper the numbers of patients that from our latest data. So what happened, you'll recall, for those of you who were part of this committee, we put in a expression of interest to the new hospitals programme to enable the funding to go ahead, and that was unsuccessful. And I was trying to recall whether I came before or after that announcement. I think possibly even before was the last time.
It was before, because I haven't had a chance to commiserate with you since the announcement was made.
So we weren't successful, and that was in part, or in quite a substantial part, because you'll have heard all the press coverage around the RAC hospitals. They needed funding. There is no RAC at Mount Vernon. There are some roof issues, ironically, but not RAC roof issues. So we have continued to look and work with the national team around what we need to do, and the urgency of it and the cost of it. The national team have accepted that actually it is a priority. We do need to make this happen. We've looked at all the alternatives. None of the alternatives are good for patients at all. And they're also all almost as expensive as building a brand new hospital. So we have gone through a process this year with the national team where we've got to the stage now where we are in an unusual position in that they will allow us to go ahead to consultation, assuming that we meet all of the requirements of the assurance process, even though we're not on the new hospital list, we haven't identified where the capital will come from. That is in part because we really need to give the clinicians on the site some certainty that actually we do agree. This isn't just, we're not just saying things, we actually want to make a commitment that this is the direction of travel. And the other thing is, as time goes on, more and more services become fragile, and we have to make some short-term decisions about what to do with those services. And we don't want to make those decisions outside of a commitment to the long-term direction of travel. And that might be around inpatients, for example, we've recently had to replace 2 linear accelerators onto the site. Actually, what would be ideal is if we're going to have a satellite unit in the north of the patch as part of the proposals, that next time we need to replace linear accelerators, we open the network's unit. But we can't do that unless we've consulted. The capital cost of that is obviously a much smaller part.
So just to sort of get to the now, obviously. So that's a good description of the history and how we got there. And I think you've been very good at coming and talking to us and consulting to us when necessary. And we've agreed with directions of travel. So you've come to us now with a specific ask about next stage.
So yes, thank you. We are now at a stage where we are looking to go ahead towards consultation. We've spoken to Hertfordshire Health Scrutiny Committee, which is Hertfordshire is the area with the largest population that uses Mount Vernon. We've met with all the scrutiny officers of about 13 scrutiny committees, and we've asked Hertfordshire if they will lead the establishment of a joint health overview and scrutiny committee to look at the proposals to see us through the consultation, and they have been developing a proposal. Nick has been involved, and the actual suggestion is that Hillingdon vice chair that, and particularly when we come to having discussions around the network radiotherapy in the north of the patch, that might be really helpful because Hertfordshire obviously have a vested interest because one of the locations is in Hertfordshire. So my ask for you really is to sort of note the progress and to consider the involvement that you wish to have as a committee. I just thought it might be useful just to be really clear on the scope of the consultation. So it's all services provided at the Cancer Centre, so that's just under 13,000 patients last year were treated at the Cancer Centre. It is also inpatients who are treated in district general hospitals at the moment because they can't be treated in the Cancer Centre. They would be moving into the new Cancer Centre. It's haematology services that particularly affects the north of the patch where they currently cannot be treated on the site and have to go into London. They would be coming back. And that would also affect some of the haematology patients at Watford. And it's also the Paul Strickland Scanner Centre and the Linda Jackson Information Centre, which are part of the proposals. What it is not is the Michael Sobel Hospice. That is outside the scope. That is not part of the Cancer Centre, and no plans to do anything with that. It's not our centre. It's not any of the services run by Hillingdon hospitals on their site at the moment, on that same site that Mount Vernon's on. And it's not. We're not consulting on the management of the service. As far as we're concerned, we've identified UCLH as the preferred provider. We had, I think, Hillingdon Health Watch was involved in that process, and we're not planning on revisiting that.
Great. So in terms of us, I mean, obviously, we are asked to obviously approve the idea that we form part of this Joint Health and Overview Scrutiny Committee, and also you're asked to agree that I should be put forward as the Vice Chair of this Joint Health and Overview Scrutiny Committee, which, to be honest, I'm happy about them being chair of a committee of 13 other chairs, which sounds like a purgatory for whoever it is, but I'm sure it's going to be a great committee. So, I mean, are we happy with those two? Yeah. And in terms of, obviously, our general sort of feedback into the process, it'll be for me to feed back to this committee about what's going on and any questions, and then bringing that to the JSOC when that arises. And obviously, I'm very happy to do that over email if necessary, certainly in meetings. That makes sense, doesn't it? Fantastic. Yes.
Just getting to say, still, obviously, we'll do the formal process through the Joint Committee. I'm still happy to come and meet with this committee as well. I think it's been a significant part of our journey together, and it would seem a little bit strange to no longer do that.
I mean, maybe, obviously, at a point where it's important enough for you to come in the meantime, I will collect thoughts and take them back. Then when we get to a more, maybe a decision point or when we have further end of consultation information, and for you to come back, that would be very welcome, actually. Thank you very much. Yes?
Just for understanding and just to clarify, you said Michael Sobel House is not part of the system at all? Nothing to do with that at all?
No, it's completely separate organisation, separately run. It's just run on the same site.
Okay, so the Mount Vernon site is the one that is going to be incorporated into the move to...
So on the Mount Vernon... So Mount Vernon is a big site. It's got lots of different things there. There's some private health providers. There's the Michael Sobel Hospice. There's the Mount Vernon Cancer Centre. There's Hillingdon Hospital has a day hospital outpatient unit there. It is only the Cancer Centre. So it's the chemotherapy, the radiotherapy, the brachytherapy, the diagnostics that's associated with that. It's the specialised end of things. So there are some inpatient beds, but they are the Cancer Centre inpatient beds, not the hospice inpatient beds.
Okay, so does anybody have any questions before we end this item, or are we happy to proceed in that way? Fantastic. Okay, well, thank you very much, Jessica, for coming and speaking to us, and obviously we'll see you again at some point in the future, and I'll see you again even before everyone else does. So thank you. Excellent, and you're free to go as well if you wish. Thank you very much. Okay, and that was fortuitous, because we shifted items around, Jan, you were able to join us for item 6. It was almost like that was planned, but it wasn't. It's just good luck. So So thank you. So if we go back to item 6, which is the adult social care market position statement, if you could give us a bit of an overview of the paper, maybe it doesn't have to be too long, 5-6 minutes, and then we can ask questions if we have. So, and just introduce who you are before you start. Thank you very much.
So good evening everybody, my name's Jan Major, I'm one of the Assistant Directors in Adult Social Care, and under my remit comes the direct care that the Council provides, but also the commissioning of services for adults and children, so over all of our external providers, alongside the quality assurance of those providers. So I'm here just to give an update on where we are with our market position statement, which is a requirement of all local authorities under the Care Act responsibilities to have a market position statement and to actually outline the ongoing dialogue that we're going to have with providers and care and support services and how to inform our commissioning intentions over the next few years. And this market position statement is for 24 to 27. It is written at the time with all the information as we know it, but it can be a reiterative document as things change, legislation changes. We would need to keep that under review and ensure it captures all of the services that we are looking. And it does focus on adult social care services, so this is a market position statement for adult social care. So it provides information about the current demand for care and support services and also how this is being met. It gives the projections of what we know about our future demand and also the opportunities for the development to provide a range and level of support that's required for residents. It is in Appendix 1 and it reflects the Council's current intentions for 24 to 27. It's intended to be read by existing providers who undertake regulated activities within the London Borough of Hillingdon, and also for other providers and organisations not currently providing services to Hillingdon residents, but to give them the scope of what our intentions are over the period of the market position statement. It is also intended for voluntary and community organisations and also people currently in receipt of adult social care services, so they can see the provision, the demand, and what we are intending to do. So the recommendations are that the Health and Social Care Committee notes the content of the report and offers any questions that you need to. It aligns with our adult social care health plan vision, which is care and support will be personalised and will prevent, reduce and delay needs. Residents will be able to live independent and fulfilled lives, supported within and by their local networks wherever possible. In the report, as it tells you about the demographics, it tells you about the demand of services, and this is for people aged 18 plus, so into adult services. It talks about the long-term services that we will be providing and the community services that we are looking to. It covers our respite services, our placements, our community services, voluntary sector and the carers support and the intentions we've got over the next 3 years.
Brilliant. Thank you very much. And so I've got a couple of questions and I'll open up to the rest of the committee who have questions. Both of my questions are based on bullet points on page 32 of your report. And the first question is around the bullet point which starts different approaches to ensure a diverse market of quality services. In it you say our approach to securing services is to ensure that residents have a choice and control over how their needs are met and access to a range of support to address cultural diversity, which will be flexible. So this sounds really positive and really good. I just wondered if you could give me a bit more detail about what that means in practice and how we make that a reality for people.
So this is looking at how we are delivering services and in relation to the services that residents are choosing to purchase through their direct payment. It also allows us to engage with residents to see the services and get feedback on the services they're receiving for commission services through resident surveys, and also looking at people's choices in relation to direct payments, but also the services that we know that there's gaps. So we're looking to see what gaps there are in the market, to see how we can develop, but engage with residents through all the forums that we hold, through the Autism Partnership Board, our disability assemblies and our older people's assemblies. So getting people's views and opinions on that to help us develop the services that we need going forward.
So, I mean, on this specific point, I mean, not for now necessarily, but I think it'd be really good if we could have some more sort of examples and data about what that means in reality, because obviously this is a really important aspect people have being able to control and have choice, and what that choice really means. So, if we could have some more examples and maybe more data about what that really means for people, that would be super useful. Thank you. So you know, at some point in the future that works well for you to send it to Nikki, and then we can have a look at it. That would be very good, because yeah, this is definitely something that is important. I think that works well. And my second question is based around the bullet point of integrated commissioning, which says over a period of the MPS, providers can expect to see examples of integrated commissioning between the council and the councils within the North West London sub-region. So I just wanted to know what sort of benefits we as Hillingdon are going to get from that.
Chair, that would really be in circumstances where, say, particularly for some of the more specialist services where there's low volume but high cost, or low volume, therefore low critical mass, which therefore means that it would be quite difficult to give that more sort of personalised approach to residents in Hillingdon, but actually working, say, with our West London Alliance colleagues might actually provide that sort of critical mass to make that more sort of economic. There's the other aspect of this as well, is doing sort of integrated commissioning with NHS partners, as I say, where it says here where that's not for the sake of it, but where it's actually going to deliver better outcomes for residents, particularly in circumstances where we're actually using the same providers as the same market.
Thank you. That makes sense. Well, obviously, with this sort of stuff, we have to be careful in some situations that our needs get swallowed up by the preference of others, but if it's in those sort of examples sound very sensible to use this model.
There would be circumstances, say, if it's actually using our market, where we may act as the lead commissioner on behalf of whether that be other neighbouring boroughs or NHS partners.
Thank you very much. Philip, you had your hand up.
I did. I remember looking at the first one of these when it first became a legal requirement, the first iteration of these, and clearly it has an important purpose to fulfil, and as an authority I think we've got a proud record of investing where we needed to make markets sustainable and to avoid provider failure, and where necessary to stimulate the market as well. A couple of questions relating to that, if that's okay. The first one is personalised care and budgets, about which we've spoken a lot over the years. Certainly when they first came out, there was some discussion about the extent to which the market was sufficiently developed to meet the level of choice people are likely to want. I wonder to what extent that is still an issue now, and whether that's something we've identified as something we need to look at. That's the first one, if I may.
So in relation to personalised budgets, we also administer the personal health budgets, where people wish to have their health budget administered and choose the services. Some of the areas that we had identified in the past were around people employing their own personal assistants. So instead of actually going to a domiciliary care agency to recruit a member of staff or through that agency, we have developed through our offer further PA recruitment agencies that specialise in matching people, and that's been quite successful recently. We've taken on a couple of new providers, not that we directly commission, but that we signpost people to, because they have a good reputation and good outcomes for people, and that has been taken up, so people are having that more choice than having to use a normal domiciliary care agency. They can actually use and employ their own PA, and it means then they can work with that person to develop their support plan and the outcomes they want to achieve. And one example of that recently that I've actually heard about is a person that is registered blind but wanted to maintain their independence and learn to cook, and they've now recruited a PA and have a cooking programme over 12 weeks to actually develop that skill. So that's really given that person the independence that they so want to keep. So that's been a really good outcome. And that's just one example, but that is something that we have really worked on and we've now been able to actually support people to do.
And that's good to know because I suppose when it comes to take up of personal budgets, the options open to people will be one of the things that they take account of in deciding whether to do that or in fact to go with a direct budget as it was. My second question, if I may, is around care homes. I'm curious about what you said about care homes in the report. It seems as though Hillingdon has quite a high number of care homes compared to other authorities. And I'm just wondering what our view is of that. There's a table on page 34 where we detail that. We talk about whether they're good or outstanding. Is the fitness for purpose of those care homes taken account of in that assessment? Because clearly some are up to date and modern. We've had COVID. There are new post-COVID infection safeguards required now in buildings. How many of our care homes are fit for purpose? Is this taken account of in this document here? I'm wondering. Thank you.
I don't think it goes into that granular detail about each care home, but we've worked very hard with our care homes to support, and we have our quality assurance team who monitor those care providers, not just care homes, but all care provision in the borough. And some care providers have improvement plans for their buildings, and they've learnt a lot of lessons through COVID about the measures they need to put in place to make sure that they're safe places. And we've had a couple of homes over the last 4 years that have decided to exit the market because they cannot continue to provide the quality care. We have a very good rating of good within all of our homes. We are comparable to the rest of North West London, and we have a high number of care homes. We have 44 care homes now, which are for older adults and for adults with learning disabilities and complex needs. So it's not just older people's homes that is talked about in this document, it's all care homes.
Just a parting comment on that, if I may. I'll take a liberty just this once. I'll live a little, shall I? I'm just mindful of what we've said in the past about wanting to keep people living independently at home for as long as possible. Obviously, and care homes can, for some, create dependency sometimes, or bring it on at an earlier stage. We're comfortable with the number we've got then, are we? Would that be fair to say? Because certainly sitting on planning, as I sub occasionally, we do get applications coming in and we're told, oh yes, there's a need for this and that's a planning consideration. I just wonder what your take is on that, if you wouldn't mind. Thank you.
I think we are very much about people keeping independent for as long as possible and keeping within the places they want to live within the community, and therefore we have a number of dom care providers that we directly commission, so people can stay within their own homes. Also, the use of telecare can help people stay within their own homes. But within Hillingdon, we have the strategy that our next step up would be for extra care housing, with which we have 3 provisions that Hillingdon are responsible for, and then we have a 4th that we have 100% nomination rights. And that's a very good option for people. And we've seen that over the last, the analysis from this year is that people are unable to stay within the community, either within their own home or within extra care, 5.5 years longer than actually going into a care home. So that is really proving positive. There will be the time that people's needs cannot be met within the community in those settings, and then a residential placement, but that would be more for complex needs around residential dementia or nursing, more than residential care, because extra care can actually meet people's needs. There's staff on site all the time if they need them, but people's packages of care are actually tailored to their needs, so they don't have 24-hour needs, and therefore they can maintain their independence more.
Thank you. Thank you. Tony.
So at the moment there are discussions with a number of providers and key providers of actually looking at that and to see if that is possible. But at the moment there is no firm plans, and I can't give a timeline, but that is still being actively worked upon. That is the intention, yes, that if we do, yes, if we are successful in doing that. So we are working at the moment because we currently have, now have 3 care homes that we directly provide within the borough, and those homes, again, because they've been in place for some 30 odd years now, they are not fit for purpose, so they are not meeting people's needs. So we are looking to develop, and also CQC, Care Quality Commission, have changed their guidance around right choice, right support, right culture, and it means they will not register going forward any new provisions of that sort of size of like 20 beds, 12 beds even. I think they're actually looking at is 6 or 7 bedded care homes, so they're more in the community and more family orientated. So we are looking at the moment to a site in Nelson Lane that is being proposed and that we need to submit a planning application for, and there are plans being designed that take into consideration the new CQC guidance, but also the lessons we've learnt from COVID to ensure that they are a safe environment and that it will enable people to live and also have family visit in safe environments in the case of any infection control that needs to be put into place.
Brilliant. Thank you very much. Okay, well, there's no more questions, so thank you very much. Oh, yes, sir, yes, cool. Yeah, go on, sorry, I didn't mention that.
I kind of a broad spec because I just feel like your response was like we've got 44 care homes, we've got a growing population of which nearly 17.5% growth in the 65 plus population. 27, nearly 30% growth in the 90 plus population. That's quite, all these languages. I just kind of want to understand: do we actually have enough? Is it meeting demand? And obviously, this is just going to keep on growing. So I can see why we're wanting to have our own and get the 2 other sites to go and get our own. But is that going to be enough? And then I also want to ask you about the workforce and recruitment of these as well, because I know that we go and recruit and we use these recruitment agencies that and some of the care homes use recruitment agencies. And what is our procurement like in looking at those? Because I have personal experience in one of the largest recruitment agencies based in Uxbridge, in this sector, who what they say on their website is not the kind of training what they're offering actually in with people. So I just kind of want to know what checks and balances we do to kind of ensure that that's been met.
So can I start off with the recruitment part first? So on the recruitment, we want to build really close relationships with our providers and our key partners, and we have done that through our domiciliary care framework, where we have 2 lead providers and then 10 smaller providers on our DPS framework. But we also have responsibility for all the care provision in Hillingdon, and we have a quality assurance team in Hillingdon. So they are quality assurance officers who go out and monitor and work very closely with those providers, and part of the monitoring is to look at the recruitment of staff and the compliance, and that also brings into the recent sponsorship licence for overseas recruitment. So where providers have a sponsorship licence, they will do some checks and balances to ensure they are following their responsibility as a provider under that, because we work very closely with the UKVI and we get notifications about sponsorship licences being suspended. And this is not just in Hillingdon, this is across the board. So there are checks, and then we will support providers where there are some failings in their recruitment, or if they have any issues, then we would look and talk about those at the Provider Risk Panel and Care Governance Board that is held within adult social care on a monthly basis, and that's oversight and monitoring of the improvement plans that providers make. It's not a punitive exercise, it's a supportive exercise, and we want to be proactive in ensuring that is happening. So that's around the recruitment, and that also applies to all care provision, supported living and care homes. And can I just ask, the first question was about, do we have enough provision? I think that goes back to the point I was making about our strategy of keeping people in their homes, and the provision we've got within our domiciliary care in Hillingdon, where we either directly commission it through our framework or leads, or people can have a direct payment. And in Hillingdon, there's circa about 60 domiciliary care providers. So they have a range, and again, they recruit different ways, but they very much recruit locally. That's how they feel it works for them. And then in relation to our care homes and extra care provision, we have 230 flats within the extra care provision that's available for people. So that would always be the first port of call that we would look at and see if it's suitable for that person. And then with the care homes, There is, but we do have some pressures from other local authorities placing, neighbouring local authorities, and that's where the joint work with the neighbouring authorities comes in, to make sure that we're not using each other's beds and placements, because we want to keep people within the community they live.
Thank you.
Thank you. Okay, before we close this item, Philip wants to come back in, and as he enjoyed so much asking 3 rather than 2 questions, I'm not somebody who likes to take away someone's enjoyment too much anyway.
This will cost me, won't it, Chairman?
Last question from Philip. And then
just quickly on extra care. I mean, it was a big, bold move, wasn't it? And we were very excited about it. I think it's important. I just wonder, reflecting back on it for the last few years, I'm wondering what we make of it in terms of take-up, in terms of occupancy and what have you. Is it what we thought it would be, essentially? Has it delivered our expectations? Or what's your take on it?
I think it has. There has been some periods where we've held a number of voids, but we work very closely. So the extra care team, the housing support team, sit within my area, and we work very closely with social work teams, and there's a panel set up that meets weekly to review cases and put them forward for extra care, and put people forward for extra care, and we work closely to ensure people can move into those properties. We are working towards a waiting list, and there's lots of initiatives to promote extra care, but I think it really is a good option for people to think about. And the fact that we have such good high standard services, you know, Grassy Meadows and Parkview were built to Sterling standard for dementia, and that meets a lot. And we've also got the resource service for dementia within Grassy Meadows, so again, that's a step in for people to learn about extra care when they're still living at home. They can come in and have some day provision. Families can see the environment, and that's quite a good stepping stone for people when they're at that point they need some additional support.
Just to add, Chair, that the extra care schemes have actually provided us, or the buildings have actually provided us with other opportunities. So during the period of the COVID pandemic, for example, we were actually using some of those flats for step-down purposes from hospital, and we that actually continued into last year. We stopped doing that last year, but we're actually about to restart that again. That helps to get people out of hospital at the earliest opportunity, but also provides an opportunity for people to actually sample that environment with a potential view to actually becoming long-term residents there.
Thank you very much. Okay, Gary, Jan, you're free to leave us if you wish. So thank you very much. That was very interesting. So, okay, I'm going to go to item 7 now, which is a verbal update on the Adult Social Care CQC inspection. It's almost ended. It'll end at the end of this week. Apparently over 120 conversations have been had with staff members, third sector providers, people such as myself and Cecile as well. We've had interviews too. Material has been submitted, which I will be sharing with everyone in this committee tomorrow, so I have it here. So it will be sent to you guys to have a look at. And the inspectors told me they expect roughly about 3 months for the report to be published. Might be before, but that's what they're expecting. So obviously when that's published, we will obviously take a great interest, and the Cabinet member and the Director of Social Care will come and talk to us about it, and I think that'll probably be November's meeting, but we can come to that when we discuss the work programme. So I just wanted to update people on where we are at. Do we have any questions? Philip?
Thank you very much, and I know I've been a bit of a pain getting on to you privately about...
You're like a pain when I do exercise. It is a pain, but it's there for good reason and benefit in the end, so I don't mind, Philip.
Critical friend challenge. No, I fingers crossed it will go well. I mean, hopefully it will. The thing that's, I suppose, not sat just so well with me, and it's no one's fault, it's about timing really. We've got this far into the process without us as a committee having a real sense of where we see ourselves on our improvement journey. Now, I know we could have helped that, but I think perhaps moving forward, there's something in maybe using the CQC framework that exists around the 4 themes for reporting purposes, so that we're closer to what's happening and we can be asking the right sort of questions in a timely way. So I would just float that as something to consider moving forward, because it just seems that's one thing. But I mean, fingers crossed it will go well, and I look forward to receiving the information too.
No, thank you, Philip. And definitely when we get the CQC report, I think it's going to be an invaluable resource for us and how we scrutinise moving on in terms of the social care provision. I mean, in terms of the actual sort of CQC inspection itself, myself and Cecil have been included in terms of what's going on and briefings in order to sort of make sure that there is some sort of member oversight about certainly confidence that our social care system, social care partners are taking it seriously. But your point is well raised, and I think going forward I can't see any problem with what you're proposing. Are we all happy? Good stuff. Okay, if that's good, then we can move on to the final item, which is the work programme. So,
forward plan.
What's that? Oh yes, sorry, cabinet forward plan. Do we have any comments on the cabinet forward plan? No, fantastic. So we can move on from that. Important that we do move on from it, though. That's good. So based on the work programme, we will discuss in a second our major review and our ideas for minor review. But before we do that, thanks to you, June, in terms of raising the Hillingdon hospice provision, I want to actually have a look at the sort of structure going forward. Now, I think, having reflected on it during this meeting, actually, having a single issue meeting on Hillingdon hospice and general hospice provision within the borough would be a very good idea, and due to what's happening, that happening as soon as possible would also be a very good idea. So unless Nikki can think of any issues that might be against this, and we're all happy with this, I would propose that our next meeting on the 11th of September, we look at Hillingdon hospice and hospice provision within the borough, and we move our health updates, which obviously, as we all know, is a very full meeting and nothing else should be on that meeting, particularly to our October the 9th meeting, which we're going to have on the 11th of September. Does that sound okay to everyone?
Would we be able to have some look into casework of people who really will be maybe affected by this? It would be helpful in regards to the decision that we make on how we look at it, because it's very important.
Yes, and also if you hear, especially when you go to this meeting on Friday, if there are people there who you think might be good for us to call as witnesses alongside the hospice providers, please do let Nikki know, because Nikki has the job of putting together the panel. So if you come across anybody who you think will be good, do let Nikki know. Thank you. Yes. Yeah, brilliant. Thank you very much. And so what I was thinking as well going forward...
Chair, sorry.
Yes.
So if we are going to be moving the health updates to the meeting on the 9th of October, we've also got scheduled for that day the witness...
I've been drawing as we've been going along, so I've been moving everything around. So yes, no, that's a very good point. So I was thinking if we were going to do that, then it would have repercussions. So what I was going to suggest is that the witness session on the 9th of October is scrapped, but what we do is we have a witness session on the 12th of November, and on the 12th of November we also have the cabinet member and the director of social care to talk about the probable CQC inspection. Then in January we have our next witness session. Then we do our findings in February, our final report in March, and it goes to Cabinet on the 29th of April. So we sort of push it all along a month. And I think that will all work, won't it? See. So yeah, but obviously we can chat about it if you think, well, if we have to work out the details, we can work out the details after the meeting. So that was what I was going to propose. So that still leaves us with a single review meeting in February and a single review meeting in April, plus obviously the witness sessions for our sort of bigger review meeting. So we're all happy with that sort of structure. Fantastic. I was drawing away when I was thinking about how to do this. Okay, in terms of the sort of major and minor reviews, in terms of a major review, and I for the public's benefit, I did email committee members with some ideas, and we had an email discussion over email just to sort of get some views before we sort of sat down and did this. But from what I sensed, there was support for our major review being about early intervention and prevention, and you know, and I got some ideas from some of you about how that could be done and finessed. So what I propose is that myself and Nikki go away, and then obviously we've got August and stuff. So before the meeting of the 11th, we have proposed report, terms of reference eked out that we send to the committee, and then we can sort of decide whether that's the correct focus within that review. Does that sound good? Obviously, all ideas anybody has, just ping emails to us and let us know while we're doing that. So in terms of our major review, I think that's good. In terms of the minor reviews, the two areas that seem to have the most support was one on the role of pharmacies in delivering frontline services, and then a second one about GP coverage and access across Hillingdon. So our two single issue reviews, one on the pharmacies, the role of pharmacies in delivering frontline services, and the second one being a general one on GP coverage across Hillingdon. So those are the two, I think, which are most popular. Is that everyone happy with that? Yeah, super.
I think, as I mentioned to you in our conversation, if it's possible, because I think one feeds into the other, is to have the pharmacy one first, because I think it's, yes. I just feel that it's new. I just think that we need to hear the pros and cons, the challenges, because we need to hear from those pharmacists about what they feel. And on the flip side, because it's taking the pressure off of GPs, but what do the GPs feel about? It's going to feed into that as well. So I just feel that if the pharmacies one had came first, because we know a little bit more about the GP services already, we get the updates and we know what's going on, but that is such a critically new bit, so that when we're asking the GP services their questions, we've got that data behind us.
I think that makes sense. Everyone's nodding. Yeah, I think that makes sense. Great, good stuff. So is everyone happy with that general work programme and what we're going to be doing over the next year? Yes. Brilliant, fantastic. Okay, come in. Yeah, cool. No, you're very well.
Just in thought, as we're looking at early interventions in care, in the care plan, I just wondered if we could focus, because one of the things that we've been hearing quite a lot across this, we've heard it quite a lot, is our changing demographics, our changing language barriers, digitisation, all of those kind of things. And I would really like that digitisation to be brought into here, because it is about the future and it is about what the plans are going to be in those early interventions to be able to enable those patients, residents, however we want to term them, into access for making things accessible without having the cost burdens.
Yeah, I think that all sounds good to me, and I think he's noted that down. So, Philip.
We shouldn't be starting from scratch with that, because that was the subject for a major review a year or two ago. So that can be built upon, possibly. Yes, that's what I meant. Yeah.
Thank you for that reminder and that reference. Good stuff. Okay, great. So are we all happy? Yes, to finish the meeting? Not in general, you can share if you're happy or not in general after this meeting. Okay, well thank you everybody. It's been an interesting meeting, and I now call it to a close.